Good evening. My name is Dr. Ted Gregorius, and tonight I'm going to give a discussion and talk on rotator cuff injuries and treatment options. So a little bit of my background. So I attended school at Loma Linda University Medical Center, and then I attended University of Florida for residency, and then Stanford for my fellowship in arthroscopic surgery with a subspecialty in sports medicine and shoulder arthroscopy. Currently, I work at Hoag Orthopedic Institute, and my office is in Newport Beach, California, and just local here. So thanks to Hoag for sponsoring this talk tonight. And tonight we're going to get into some issues about the rotator cuff. So I see a lot of shoulder in my practice, and the first thing I do with patients is I like to discuss the anatomy because there's a lot of confusion about what's involved. So it's pretty straightforward, and I apologize for this busy slide, but there's three principal bones in the shoulder that we're going to consider tonight. So one is the scapula, which is the larger bone in the back and forms the socket of the shoulder. And then there's the humerus, and at the very top it's the humeral head. And then there's the clavicle. So those are the three bones. So in this view, we're seeing images of a right shoulder from the back on the left side of the screen, and then the front part on the right. So again, we're primarily focused on the ball and socket. So in addition to the bony anatomy, there's the soft tissue anatomy. And this is really the principal focus of our discussion tonight. So there's four tendons of the rotator cuff. And frequently I'll get patients who say rotator cuff, and they're not sure because it's passed around fairly commonly, and it's confusing for a lot of people. It's really simple. There's just four tendons of the cuff that wrap around our shirt, just like a cuff on our shoulder. And so you can't feel or see those tendons because they're deep to the deltoid muscle, which drapes over the shoulder like a gentleman's coat or like a shawl. So you can see in this image here, that larger muscle that's encompassing the shoulder or covering it is the deltoid. And so the deltoid and the rotator cuff perform a specific activity. They're counterbalanced each other. So I give this example again a lot, and so I have young kids, and so if I take my kids to the park, I'll sit closer on the seesaw to the middle, and my kids will sit further away. So as they age, I will move further back, and so it balances. And so in the same way, the rotator cuff pulls the shoulder in, and the deltoid pulls the shoulder up. And so those two forces are necessary to create what's called a force couple. And another way of thinking it is like a reverse ball and hitch joint. So like a hitch on a car, except the socket would be on the truck side or the car side, and the socket would fit into it. And so if there's any change to this force couple, meaning the rotator cuff or the deltoid, that results in pain. So this is an example of a rotator cuff tear of the supraspinatus tendon, which is the tendon that's on top of the cuff. So it's the highest tendon. Again, you're not going to feel it because the deltoid's covering it up. But if the tendon's torn, the head will rise upward because of the more powerful deltoid pulling it up. So it's really important to restore this force couple, and that's what we're going to discuss tonight. So when your rotator cuff is torn, as a result, you can develop what's called outlet impingement, and in some cases we develop outlet impingement, and frequently I'll hear to this as bone spurs in the shoulder. And so while that's true, it's not exact. It's actually due to the curvature of the bone on top, the acromion bone, which is part of the scapula. So that bone can curve down and cause pinching when we lift our hand into the forward direction and cause pain. So it's difficult to tell sometimes the difference between impingement, which occurs with a rotator cuff tear, or if it's impingement alone. Again, we'll get into more detail on that as we go along. So this is an example of someone who has impingement. Again, we're looking at a right shoulder, and in the view on the left-hand side of your screen, the shoulder's abducted out, and you can see that the shoulder's engaged and it's pinching on the bone, and that spurring then pinches the rotator cuff and it wears it attritionally. So that's one of the things we address when we take care of rotator cuff injuries. So when I see a patient in clinic, I will almost always get X-rays, and the reason is because I want to see the bony anatomy. The X-rays are not helpful for rotator cuff anatomy per se, but in some instances, the rotator cuff tear is so bad that it actually shows up on an X-ray. So what happens is in the picture on your left-hand side demonstrates a massive rotator cuff tear, and you can see that the ball is no longer in the socket, whereas the film on the right side, you see that it's the normal force couple. So the person on the left-hand side of your screen is going to require a different type of procedure than the person on the right. Both images reflect someone with a rotator cuff tear. It's just that you can't tell from the images on the right as opposed to the left, where you can say clearly this person must have a rotator cuff tear. So again, when you visit your doctor, there's value in getting a regular X-ray because it tells us if there's arthritis. It tells us the relationship of that ball and socket joint prior to getting a more advanced study like an MRI. So again, rotator cuff tears can result in secondary impingement, and as you move the arm up and down, and that in turn attritionally worsens the rotator cuff tear and eventually leads to rotator cuff arthropathy, which means the tendon's so far retracted or pulled back that person can no longer lift their arm. That leads to active motion loss and a lot of difficulties with just day-to-day living. So driving your car, lifting groceries, reaching for something in the cabinet, again, combing hair, shaving, those types of things can be pretty affected. And a lot of people, most of our activities is below our shoulder, but again, these are important activities for reaching upwards, and that's where you're really gonna know when someone's got a cuff tear. So what are the signs and symptoms? So this afternoon I saw a gentleman in my clinic and he was pointing out, he said, my pain is right here. So that's deltoid or referred pain. And he described it as a aching pain. It wakes him up at night. So that's some of the most common complaints I get. And often people are confused because they think, well, the rotator cuff is up here, so I should have pain here, but it's referred and it's most often in the mid-deltoid. This is really important that we discuss the symptoms because a lot of people will come to my clinic and say, my shoulder hurts and I feel numbness and tingling down my arm. And that's really neck pain. So out of every 20 patients I see with a rotator cuff injury, probably about anywhere from 15% or more will have an associated radiculopathy, which means that there's a pinched nerve in the neck and it'll masquerade as shoulder pain. And I've even been referred patients with an MRI that have a rotator cuff tear, but actually they're not suffering from pain from the cuff, they're suffering pain from the neck. So again, these symptoms are the most common. So overhead weakness, you can't reach your hair behind your back, and your doctor can lift your arm or but you can't lift it actively. So this is active motion. When you assist someone, that's passive motion. So that accompanied with night awakening, sleep disturbances, all very common for rotator cuff injuries or problems. So these are the most common symptoms to look out for and things you want to tell your doctor about. So I get the question, what causes rotator cuff tears? So absolutely, rotator cuff tears will occur in the setting of trauma, such as a fall or an accident, sports, but frequently they just occur because of repetitive motion in our age. So as we age, we're more and more susceptible to rotator cuff tears. So when we're young, you want to think of the cuff, the tendon is thick, almost like a canvas-like material, and as we age, it becomes more and more like a t-shirt or paper mache, and so we're more at risk for rotator cuffs as we age. But statistically, if you look at a population that doesn't have symptoms, we call asymptomatic, you're going to see about 28% of the population at age 60 are going to have a cuff tear. And then at age 70, it increases upwards of 65%. So again, most people will have an incident that aggravates or exacerbates their rotator cuff tear, such as a fall or accident. And then some people will have a family history, then other things like smoking can affect the health of the cuff. So what happens if you just leave your cuff alone? So let's say you have a fall, you're symptomatic with your shoulder hurts, but you don't have symptoms yet. So those rotator cuff tears, which are have no pain, but are they tend to be active and increase within 2 to 3 years of that injury. And we'll get into more of that later because it has to do with the atrophy that can occur in the cuff and how we fix them. And then cuff tears, which are symptomatic, progress to larger tears over a period of time. So it's important to address these injuries. So what are your options? So again, we always recommend seeing your doctor, and that can be your physician's assistant, your nurse practitioner, your family practice doctor, your internal medicine specialist, and get the ball kind of rolling and say, hey, look, this is where my pain is, and they'll help you clarify, is that shoulder pain? Is it neck pain? Where's that pain coming from? And they can start the workup, get an X-ray, get you referred to an orthopedic surgeon with specialty training in shoulder surgery. So interesting enough, even though I am a surgeon and that's what I'm trained to do, the vast majority, upwards of 95% of my clinic is treated without surgery. And again, physical therapy plays an important role in rehabbing the cuff and restoring the force couple that we talked about earlier. So you want to restore the relationship of that seesaw, the deltoid versus the rotator cuff. So a really great website for a physical therapy program is at orthoinfo.aos, which is on this slide, and they have a home exercise program and information that's free and readily accessible from the American Academy of Orthopedic Surgeons, which board-certified surgeons are frequently members to. And it's a great resource for information, and it goes into detail about rotator cuff injuries and about home exercise program. So in conjunction with that home program, I also frequently utilize physical therapy because that's an important role. Therapists are really valuable in providing information to patients to help manage their injury and restore them to full function without surgery. So remember, why it works even if you have a cuff tear is because you have redundant tendons of the rotator cuff. So you can train those muscles to help restore that force couple. So that's how therapy works. So we don't expect the cuff to heal in therapy, but we expect it to compensate and restore the force couple. So again, one of the most important exercises or two exercises is the subscapularis strengthening. So this helps restore the function of the isolated subscapularis muscle to pull the head back down through this functional program. These are 4 exercises from the AAOS, the American Academy of Orthopedic Surgeons website, that talk about these exercises and how they can be integrated with both a home program and a formal physical therapy to restore that force couple and get you back to activities. So other things that we use almost on a routine basis are anti-inflammatories in conjunction with the home and formal physical therapy. So ibuprofen, meloxicam, naproxen, they're all valuable medications, and most of them are over the counter. It's important to identify the right anti-inflammatory. So not everybody's going to respond to ibuprofen with the same efficacy or meloxicam or naproxen. So frequently I'll have patients try different medications over a course of a week to 2 weeks to identify what works best for them. But you need to be careful because there are side effects to these medications, so, such as complications with stomach, gastroesophageal reflux or a GERD, easy bruising. So we use them for short term only. Additionally, we like to use an injection. So corticosteroids or steroid injections can play a role. So in the office, we'll use an ultrasound guide to place the needle so we know that it's not hurting the rotator cuff. And that will allow patients pain relief in conjunction with their anti-inflammatories for a period of 30 to 60 days. And during that time, while they're attending physical therapy, they'll be able to restore that force couple by increasing the strength of the tendons that are intact. So by controlling the inflammation, you're going to help the therapist and yourself through your home program to restore that force couple. It does not heal. Again, and corticosteroid injections can even be harmful to the shoulder because corticosteroid can, with repeat injections, have an effect on the structure of the tendon itself. So we want to be careful. I have seen too many patients come to my clinic that have had multiple injections over years, and unfortunately I can't fix their cuff and I have to do a shoulder replacement. So there are some other very popular injections. Platelet-rich plasma has gained increasing popularity over the past 25 years. It's used ubiquitously in orthopedic surgeons' office, but it's not FDA approved. So there's a lot of research being done. Stem cells are also available, and those are still being researched in terms of their efficacy. So those are expensive alternatives. So we try to stick to what's affordable and what's known in science. So if the pain continues, what should you do? So let's say you've exhausted physical therapy, you've done the injection, then you're referred to an orthopedic surgeon who has specialty training in arthroscopic surgery. So you want to get an MRI. So one of the first steps once we consider surgery is obtaining an MRI. And the MRI is different from a CT scan and radiographs because it focuses on looking at soft tissue by using magnets that rotate around the body to look at the soft tissues and help us understand what's going on. So we can identify the rotator cuff tear, we can identify the impingement, we can show what injuries are acute or what's chronic. And so acute, what happened immediately versus what's occurred over a period of time. So for example, in this film, this is a cross-sectional image, which we call a coronal image, and we can see the tendon on the very top. It says the torn tendon with the arrow pointing to it. We can see that that tendon's been torn for a while because it's atrophied. So just like a muscle that atrophies, it gets skinny, we see the cross-sectional area is getting smaller, and we see the tendon retract. So that's an important aspect that your surgeon needs to consider when recommending surgery, is how a chronic tear or an acute on chronic tear may be affected by the potential surgery that's being performed. So if a tear is chronic, there's a higher rate of that tendon failing. And many studies that we've done, that can be as high as 25% and even higher. So again, the acuity of an injury is important to understand in the context of that discussion with your doctor. Did you fall, a couple weeks ago and you can't lift your arm, or did you fall 6 months ago or a year ago? So those are important aspects to discuss with your surgeon. So with regards to surgery, there's lots of different ways to do surgery. In my practice, I prefer to do an all arthroscopic knotless technique. But there's different ways of doing it. Some surgeons still prefer to do open, and there's no wrong or right way to do surgery. It's really surgeon preference. So if you go to your surgeon and say, I want an arthroscopic surgery, yet that surgeon is trained in an open technique, probably the best to let them do what's best in their hands. So there's a preferred technique based upon the surgeon's training. So again, my training is all arthroscopic, and so that's the way I do it, and I find it to be the most effective in my hands. So this is an example of a massive rotator cuff tear, and that means that there's greater than 5 centimeters retraction, and there's more than 2 tendons torn. And so in this technique, you can see that sort of U-shaped tear. And so my preferred technique now is I don't use suture, I use tape, because tape has a broader footprint, and it allows me to co-adapt that. So we pull that together in what's called a margin convergence. We're converging 2 margins together. And then after, we sew that margin back to its insertion point, which is on the top of the humeral head. So I find that it's easier to do arthroscopically because I'm able to visualize it, and it's not bloody. I can see it. It takes me less time. Those take about an hour to do arthroscopically. And I can do a transosseous technique, which means it's equivalent. We call it a transosseous equivalent because it's equivalent to having the shoulder opened and running sutures transosseously or through the bone. So it's called a knotless transosseous equivalent technique. So this is, again, the way we do it. This is an example of an open incision. It's often called a saber incision, and it's cut over the shoulder, and then you move the deltoid from the field, and then you can see the rotator cuff and go ahead and repair it open. And again, that's all surgeon preference. Okay, so this is an example of arthroscopic. So we're using a camera that's through a video monitor in which we're watching the operating room. And one hand controls the video, the other is using to operate, and then we use our feet as well as our fingers to perform different pedals. It's done as an outpatient. Again, the time much more pleasant and doable. To help avoid using narcotic pain medicine and making the post-operative time much more pleasant and doable. So what is the rehab like for a rotator cuff? So I see everybody back within 7 days of their surgery, and most patients have to wear a sling for 4 weeks, up to 6 in some cases. And during that time, they're coming out of their sling about every hour for about 10 to 15 minutes. They're dropping their hand to their side, and they're doing pendulum swings. That goes on for about 6 weeks. By the end of 6 weeks, you're in therapy this whole time. So from week 1, you're in physical therapy. So working along with a therapist with a specific protocol to do those exercises twice a week for 12 to 24 weeks. So by 3 months, the vast majority of patients have a full range of motion and they're returned to basic function. And by 6 months, we consider the rotator cuff healed. But I see in my practice that most patients will continue to do well up to 12 months and continue improved outcomes. So what happens if you have a rotator cuff tear and you've left it and you see the surgeon says, I'm sorry, I can't fix that rotator cuff tear. It's too retracted, meaning that you put a stitch in it, and instead of that nice canvas-like material, instead you have that paper mache. So if you put a suture in, it's just going to tear right out. So in this example, we see in this shoulder a massive retracted rotator cuff. So there's nothing left to fix that rotator cuff, and you can see at the top of the screen that white appearance is the absence of the tendon, that's fluid. And you see at the very end of that yellow marker, the stub of a tendon. So that would not be repairable. And even if you could move it, that would be difficult to have it reattached to bone. So in some instances, there's other options, and we'll go over those. So one is a shoulder replacement. So for a massive rotator cuff tear, we frequently use a reverse replacement, and patients are overwhelmingly happy with this prosthesis. In this example, we see in the bottom left-hand side of your screen, we see a massive rotator cuff tear, and you can see the white area is fat infiltration, meaning that the cuff is gone. So we get an X-ray and we see, well, this person would be a candidate because their deltoid, the outside muscle, is still functioning, so we can truck the shoulder into a reverse arthroplasty. And that allows a patient to have excellent function. That operation also takes about an hour and a half to do. And we do them outpatient now, but a lot of patients will stay in the hospital overnight, and the outcomes are very good with that prosthesis. So in some instances, though, I'm able to do what's called a superior capsular reconstruction. And so this is an interposition arthroplasty, meaning that you position a graft in the shoulder on top of the rotator cuff, and then you reattach the remaining tendons. It's also done arthroscopically, and it's been really exciting because we help patients who don't have a rotator cuff, or excuse me, they have a rotator cuff, but the superior tendon is torn. So that's been very promising. I've had really good outcomes with patients with this, and it's a great option. So it's something you want to talk to your orthopedic surgeon about who has specialty training, because it is a complex procedure, but it does very well, and it takes the same amount of time of healing as a normal rotator cuff. So I want to thank you. My email is tgregorius@calortho.org. So if you have any questions, I'm happy to answer them for you. Looks like we have some questions tonight. Okay, let's see. Yeah, so this is a good question. Can a rotator cuff be healed or strengthened without surgery? So it definitely can be strengthened, but it cannot heal because of the environment what the tendons live in. It's a what's called a vascular watershed, and what that means, it's like a sprinkler on a lawn. So if you see a sprinkler on a lawn and its radius of curvature, you see that the lawn is watered within that area, but on the outskirts of that area, the grass may be brown. And so that means it's not getting good water. And so the rotator cuff doesn't have great blood supply. So once the tendon's torn off the bone, the only way to reattach it to the bone is through a procedure. There is some people that believe you can fix rotator cuffs through other means, but that has not been borne out in the science, such as stem cells and other things. So again, yes, it can be strengthened and you can restore the force couple, but it can't heal in the conventional way. So yeah, it's a really good question. Does a rotator cuff hurt all the time, but why is pain worse at night? So yes, it can bother you all the time, but the reason it's worse at night is because during the nighttime when you lay down, the force couple is particularly accentuated. In other words, the rotator cuff, once it loses its ability to hold the shoulder in the capsule, the shoulder is then loose, and the humerus then slides out of the joint, in a way subluxes. It doesn't dislocate, but it subluxes, and it's banging onto the undersurface of the acromion, and that's really painful. So again, at night, when we're in this passive state of sleep, the rotator cuff can bang onto the other bone, the bone spur, and cause a lot of pain. So again, that's a really common injury, and that's why it doesn't hurt as bad when you're activating your shoulder per se. So it's not going to hurt all the time, but it's definitely going to bother you at night, and certainly when you engage in overhead activities, but maybe not as much when you're sitting and your hands resting at your side. Okay, how long does a rotator cuff injury take to heal? So again, so typically once it's repaired, it's the first real ingrowth is going to occur at about 12 weeks. So we know in the science through research models that the integration of tendon to bone is going to really commence. It's early on, but we're going to first, good healing is about 12 weeks, and it's going to take up to 26 weeks, depending on the study you read. So I typically tell people 6 months. But again, during that time, remember, after your rotator cuff is repaired, you're going to be in your sling for 6 weeks. Your motion should be restored by 12 weeks, but you're not functionally returned to all your activities prior to that 6 month time. How can I make my rotator cuff heal faster? Do nutritional supplements help? That's another really good question. So again, there's a lot of studies done to it. There's not a nutritional supplement per se that helps someone heal faster. So you want to be really careful. It's important. So glucosamine chondroitin and things of that nature are very controversial. And even though they're used ubiquitously, there's a lot of, the reason it's not FDA approved is because the science hasn't been borne out. So you want to be careful about what you ingest, and you really want to talk to your internal medicine doctor, your primary care doctor, your orthopedist. Are these supplements good for me? Because there are side effects to these medications. And I always get concerned when I go to the grocery store and I see someone who's a little bit older, and I see them pushing out a big cart of this glucosamine chondroitin and seeing, man, that's really expensive to pay for all that medication. And even though it's advertised on TV, it doesn't mean that it's true. And so a lot of these drug companies advertise, but they're not telling the whole truth. And so you really want to talk to your doctor. Doctors are a good source of information. So I'm not aware that a nutritional supplement can help per se, but there are adjuvant things which we briefly mentioned, like PRP and stem cells, that you can talk to your doctor about, but they're not FDA approved for treatment. So I have a couple more questions. So our rotator cuff surgery is done at a hospital or surgery center. So they can be done at either place, but for the most part, sports medicine surgeons or arthroscopic surgeons tend to do them at an outpatient surgery center. And fortunately, Hoag has a lot of great facilities that we use that are outpatient. We can do them inpatient, but the surgery is actually fairly quick now, and it's a lot different than it was even 10 years ago. So because of the brevity or time that's spent at the hospital, you can really go home safely the same day. Now that may not apply to some patients that have other comorbid issues, but overwhelmingly people can be discharged home the same day and do really, really well. Again, the surgery takes about an hour, depending on your surgeon, hour and a half maybe. The total time at the hospital is about 3 hours, and you should safely be able to go home without any problems after the surgery. So pain management after surgery, are there any tips? So yeah, absolutely. So I get to spend a lot more time with my patients than my anesthesiologist colleagues, but Hoag has done a great job of really giving us top-notch anesthesiologists. And one of the benefits are when they come to talk to my patients before surgery, they say, would you like a block? And so sometimes patients are kind of surprised, well, what does that mean? So a block, again, is putting, using an ultrasound guide to numb up some of the nerves that supply the pain receptors in the shoulder, and they can deaden those, because the really critical pain after surgery is the first 24 to 40 hours. And fortunately, these new blocks have done really well on eliminating a lot of the post-operative pain. I frequently now see patients that don't even use narcotic medicine after surgery. So that's a really important aspect of care. So I really encourage patients to talk to their anesthesiologist before surgery. And at Hoag, again, we're blessed with fellowship-trained anesthesiologists that are excellent in providing those regional anesthesias. So that's one thing. And then ice. Ice has been around since the beginning of time, and unfortunately, we don't use it the way we should. My partner had a surgery, and he was telling me ice was better than anything else. And I couldn't agree. I've had multiple orthopedic surgeries, unfortunately, and ice has been the best after surgery. So having cold therapy or ice available, ice packs, is really going to help a lot with your pain control. So icing, getting a block, and then talking to your doctor about the right anti-inflammatory, perhaps in conjunction with a narcotic pain medicine if one is needed. So we always cover that, but we want to focus on the non-narcotic modalities. And again, Hoag has done a really good job of educating our patients on ways to avoid using a lot of narcotics after surgery. So again, I find most people don't require it, and they're able to get through surgery without with narcotic medicine. Thank you very much.